said, I'm a physical medicine and rehabilitation provider and originally from Puerto Rico. So we're going to try to incorporate some little bit of Spanish in some of the concepts here. I told the team that if I forget to bring some Spanish names and concepts, please remind me. I'm happy to say them. So one of the things that I love doing the most is watching basketball, and as part of that, I like seeing basketball players and athletes as part of my clinic. And so we're going to focus today in kind of the basic and the most common injuries that I see in basketball players, and a little bit of my experience and what kind of things you need to know that are important in terms of covering a basketball game as part of being a sports doctor. So I don't have any relative financial relationship, but I've been working with different basketball teams for the last couple of years, including the Puerto Rico basketball national team, and more recently with the U.S. basketball junior national teams in the last couple of years, which had been a great experience. Last year we went to Spain, and the U.S. team won the gold medal. So that was definitely fun.
That's fun, yeah.
So the objectives would be to kind of explain the essentials of the coverage of basketball in the sideline, discuss and review the common upper and lower extremity injuries, and discuss maybe the application of musculoskeletal ultrasound. And then one of my passions also is ACL rehabilitation. So I want to talk a little bit about the importance of a good rehabilitation after an ACL tear. So let's start with the sideline coverage, okay? And the role of the sports physician is to kind of organize and coordinate the medical staff and develop an emergency plan to help ensure safety. The main reason for the doctor is making sure that you address any emergencies that can happen in the game. But if you're also traveling with a team, you have to be a doctor that can cover anything else. Like if somebody gets like a cold or diarrhea or things like that, you need definitely needs to be prepared to help with those things. But once in the court, which is the main reason that you're there to manage emergencies, there's a few things that should need to be familiar. And number one, I always said you have to be familiar with the arena or the gym, and you have to know where the exits are, and you're going to know that if there's an emergency, where you're going to leave to find the ambulance. So you're familiar with the stadium or the arena. The second thing is always go and say hi to the EMT team, because usually in these kind of big tournaments and high school football and this kind of thing, there's going to be an EMT service right there. So it's very important to go and say hi, introduce yourself, and come up with a plan in terms of emergencies. Hopefully they have an AED, and if not, you should have one, because that's one of the things that are extremely important in covering sports, especially basketball. And I always ask, what is the nearest hospital? So everybody's on the same page where they need to go. And when you travel with kind of teams to tournaments, usually there's a hospital that is already informed about the tournament, so they know that emergencies can come by to that hospital if needed. And then you have to make sure that you have the necessary medical equipment that you need to try to cover the game. So what is in my medical bag, which are essentials in basketball? There's more things that you can have there, but these I feel that are essential in especially in basketball. And we need to have the AED. That's the most important thing. You can forget everything else, but that's the most important thing that you need to have there. You may have to have some epinephrine for possible allergic reaction in your trip, antihistamine, albuterol for asthmatic patients, and then a stethoscope and blood pressure cuff. For spine injuries, you need to have like a stretcher and a spine board. Cervical orthosis. For injuries in the mouth, you need to have like a save a tooth kit to make sure that you put it there and see if we can save it. For fracture and dislocation, sometimes immobilized or sling crutches can be helpful. And then if there's some cuts, we need to have the wound care equipment, including sutures and suturas en español, to kind of help the patient avoid going to the ER. Maybe you can take care of the patient. So in terms of medication, I always like to take medication, some antibiotics, especially if I'm traveling internationally. Some pain medication like NSAIDs or acetaminophen, antiemetic, antidiarrhea, antihistaminic. Those are very important when you're traveling to places that maybe the water quality is not good and you can have some episode of diarrhea in some players or coaches also. EpiPen, like I said, albuterol and oral fluconazole are things that I like to take. So the first thing that I want to start is the most important thing to kind of be prepared is with the sudden cardiac death in athletes. And I don't know if you have seen the recent news. There have been a few cases, especially in basketball, that unfortunately one kid died this past weekend from a sudden cardiac death. And also LeBron James' son, Bronny James, also had an episode, but fortunately he was able to survive that episode due to the quickness of the response from the staff team. So
Deontay head drop, snowball, sudden collapse.
So this is the scare when you're covering games, and this might be a little bit strong, but these are the cases that you see the player running and nobody touched him, and he just had like a sudden collapse without nobody touching him and without protecting themselves. So these are the most scary thing that you can see. I have seen it in football, but it wasn't the heart. The patient had like a spleen laceration. Right, the hit before he collapsed, but it was very scary running to him to try to take care. So these definitely are the things that are scary. And the most important thing to be prepared is understanding your cardiopulmonary resuscitation and also having an AED right there to CPR. So the survival rate, if you start CPR very quickly, it can be close to 50%. Without CPR, when the heart stops, definitely the percent of survival is very, very low. The greatest determinant to survival is the time to start defibrillation. So the collapse can be for different reasons, but if the heart stops, we have to restart it. That's where CPR is important, but also trying to defibrillate the patient to try to get him back. And the survival rate declines for every minute that you lose to place the patient with the AED to try to defibrillate the patient. So the goal is to apply this within the first 30 minutes of collapse to avoid any kind of complications and further problem to increase the chances of definitely starting. So when you see this kind of happening, you have to run already with the AEDs. And all these cases that you have here in the news that the patient survived, they have done a great job implementing these cardiopulmonary resuscitation protocols. So this is the most important thing that you're going to learn today. The other things are not emergencies that can be treated eventually, but this is kind of the biggest scare and emergency, especially in basketball and football. So now let's go to more specific basketball injuries. The most common injuries are in la extremidad inferior, right? The lower extremities. And this is kind of very obvious. So 2/3 of the injuries are going to happen in the lower extremity, with the knee and the patella being the most common joint that gets affected. Only 1/3 of the injuries are going to be localized in the upper extremity or the face or concussion, for example. So let's start with the upper extremity, and this is a shout out to my partner, Dr. Troyer. He's a soccer fan, so we always joke around that I can use my hands and he doesn't, but I put him here in a picture with upper extremity injuries. So let's start with the shoulder. So not a lot of injuries in the upper extremity, like we said, but one of the most common thing that we can see is dislocación de hombro, right? Shoulder dislocation. And it's not that common, but it can happen. And the mechanism of injury is basically falling on the outstretched hand, usually with external rotation and abduction of the arm, is when you have possible instability of that shoulder and you can have anterior dislocation. The examination, definitely you're going to see a deformity in the shoulder. The patient will not move the shoulder and will try to avoid any type of movement, including external rotation. And we have to check for possible vascular compromise or nerve nerve injuries. They actually have to do x-rays. There's a big injury and you're suspecting that he may have a fracture. Maybe it's a better idea to get x-rays first. But less than 1% we have a fracture after this episode. So definitely it's better to have an x-ray, or it's recommended to have an x-ray after the relocation to make sure that it's in place and also confirm that there's no evidence of a fracture or a bancar lesion, which is a heel sac lesion, which is also something that can happen with shoulder dislocation. So what is my preferred technique to try to relocate the shoulder? And there's multiple techniques and none of them are good. This is kind of 60% success rate, but most of them are like around that range. So it's kind of close to 50-50. But I like this one because it's not that invasive. So basically we have the patient sitting there, sitting with the knee bent like him. We kind of wrap their hands, or he can grab his knee with his hand, and you can see the right shoulder on him. We just ask him to lean back, and you see the right shoulder, he's just leaning back, and just allowing the gravity to kind of do his works. He started relaxing a little bit, doing himself, and you can see on the right shoulder, he's going to feel soon something get in right there. So you can see it that it went in place. So I like this approach because I'm not forcing it, I'm not cranking the shoulder. The patient is less apprehensive because he feels in control. So I feel we have a better chance of this kind of working. Sometimes I also can massage the muscles around it to try to relax it to see it kind of comes into place. But this is the Davis technique and method. So another thing that can happen in the upper extremity is dislocations of the fingers, and this can be caused because of direct trauma from the ball. So una dislocación de la articulación PIP, proximal, del dedo. There's different type of dislocations, and the most common one by far is the dorsal dislocation, which is the one that you see in the picture. There's a possible concern of a ball or plate disruption, but usually most of the cases do not have any ligament injury and we can relocate very quickly. And the lateral dislocation are not very common, and the volar dislocation are very rare. It's a little bit more concerning and hard to relocate. You can definitely do some axial traction and gradual rotation of the wrist to see if we can put it in place. And then we have to immobilize for a while to try to decrease the chances of a boutonniere deformity. The other thing that actually is very common is mallet finger. I don't know if you have heard this concept before, but it's a direct axial load into the finger. So it's similar to the dislocation mechanism, but instead of a dislocation of the finger, the extensor tendon that inserts in the DIP joint kind of gets ruptured, and then you develop this kind of flexion deformity that you can see in the picture, that you can flex the DIP but you cannot extend it because that extensor tendon is torn. So you can do an x-ray to make sure that there's no fracture, but also it can also give you some information about avulsion fragment in this area. The treatment usually is conservative and non-surgical. We need to immobilize for at least 6 to 8 weeks. And there's different way to do it. You can use the oval 8 finger splint, which is the one right there, and or the Stax finger splint. Also, sometimes you can send to occupational therapy, and they can create like a homemade splint. But the important thing is that the patient cannot flex the finger for 6 to 8 weeks. They can remove the splint, but they can need to keep it straight. So I recommend for them to put the hand on the table flat, do their thing, and then put the splint again, because if they flex it just one time, we have to restart the clock 6 more weeks, okay? So that's something that I emphasize a lot. Most cases, sometimes I see this in kind of older patient that is not related to basketball. And sometimes if it doesn't heal, they don't care and they can continue to live without it. But in basketball, since you need to kind of dribble and use it, if it doesn't heal, it might require some surgical management. But in most cases, they heal. The other one that actually is more important to identify is jersey finger, right? And the name comes when the finger gets stuck in the jersey of the opponent and you have like a hyperflexion, a forced extension of the DIP area. or in a basket netting, like they threw the ball in the basket and the net, kind of the finger got stuck there. And basically this is a tear of the flexor digitorum profundus tendon inserting the DIP. So you can see that the problem is that they cannot extend the DIP joint, and when they close their hand, they can close everything except that finger. You can do an x-ray again, probably will be normal, and we can immobilize it, but this is the difference, is that this is actually a surgical diagnosis, because the tendon tends to retract and it doesn't heal very well with conservative treatment. So this is one that we need to identify in order to make sure that we repair it if we need to, okay? So now let's start with the lower extremity injuries, which are extremely more common, okay? And one of the most common injuries is esguince de tobillo, right? Ankle sprains. Esguince de tobillo is in Spanish. The most common ligament that gets affected is the lateral ligaments, definitely more than medial, because of the mechanism of injury is more common, the inversion injury that you can see in there in the picture. The most common ligament that gets injured is the ATFL, then followed by CFL, and then PTFL. Usually when you have PTFL, you have all three. So we said that the mechanism is that awkward landing from jumping. So usually patients in basketball, they jump, and if they land in the foot or in the tennis shoe of another player, they can develop this kind of inversion injury. The other thing that we need to identify, if they develop like a high ankle sprain, which is a little bit more serious and the return to play is a little bit longer. And the worrisome is that it can cause some syndesmotic and widening of the syndesmotic region there in the distal leg. It has definitely swelling, pain, positive anterior draw and tilt squeeze test. And also there's the squeeze test that you can kind of squeeze the fibula and tibia and see if that helps. The x-ray can help to make sure that there's no associated fracture, but also they can identify the widening of the space. Ultrasound can evaluate for all the ligaments that we discussed, including the AITFL, the anterior inferior tibiofibular ligament, which is the one that gets injured in high ankle sprain. And MRI is still the gold standard, but I feel that ultrasound also is very helpful and it's very close to that.
The benzos, what do they do?
Sorry?
GABA.
Sorry? All right, I think we continue. So the management will be definitely conservative treatment initially, ice, compression, early mobilization. I'm not a fan of the walking boot. Some people put it. Sometimes in high ankle sprain, I consider it, especially if they're limping a lot, and I do it for like a week or maybe 2 weeks max, but I try to avoid it as much as possible. I definitely am a fan of the lace-up ankle brace to immobilize it, and for other reasons that we're going to discuss soon. But definitely rehab is the best treatment option for this. And the target and the important concept is to improve la propiocepción y el balance, which is the balance and the proprioception. Because when you have an ankle sprain, you lose all those things, and you're predisposed of having a second ankle sprain if we don't do a good job with the balance and proprioception retraining in terms of firing of the neuromuscular fibers. So let's talk a little bit about ankle sprains, which is an interesting concept because I'm not a fan of immobilization, but actually the data for ankle bracing is actually pretty good. And basically, if the patient have an ankle sprain, all of the athletes need to be on an ankle brace. The reason is that it has been shown that it can prevent secondary ankle sprain, like it can prevent a second ankle sprain. And actually, there's some data that it can prevent the first ankle sprain. So if you use it from the beginning, it can have some preventive kind of results. I don't think that we're there yet that we recommend on everybody the ankle brace, but I've been doing it in some volleyball players, which is very high geo, the use of this because they develop a lot of ankle sprains. After they have an ankle sprain, I recommend to use a minimum of 6 months before stopping the use of the brace. In the meantime, they're doing rehab, they're doing strengthening, they're doing balance and proprioception exercise. And it can be up to a year of use, depending on how they're feeling. I like the lace-up ankle brace, which is the one over there. That is the ASO, which is kind of pretty rigid, but I like it. For basketball, it works pretty well. For soccer and other sports, that the shoes might be a little bit too bulky for that shoe. So maybe a different one would be better. But for basketball, it's pretty good. Another thing that we can see is Achilles tendinopathy, which is a degeneration of the tendon. I'm not going to talk too much about this, but the important concept is to distinguish between mid-portion and insertional tendinopathy, because the treatment might be a little bit different. We can do x-rays, we can do ultrasound, we can do MRIs. And this is a 60-minute talk of different treatment options, but this is kind of my protocol of different options that I consider. Definitely rehab therapy, eccentric exercise. We can use topical nitrates. We can do extracorporeal shockwave therapy. Steroid injection for Achilles tendon is not a good idea because it increases the risk of rupture, so we never do that. But for other tendons, it can be considered. If it's mid-portion Achilles tendinopathy, there's a procedure that is called high-volume image-guided injection with tendon scraping. That it can be a great option for this. If we have patellar tendon, also that can be a great option for that problem. And I have done a few basketball players for this with great results. One of them, like 6 months later, sent me a picture of he winning the dunk contest of his league. So that was pretty good. And then we have advanced procedures like orthobiologics and maybe some ultrasonic percutaneous tenotomies like the 10X device or the 10-jet devices. So Achilles tendon rupture is one of the biggest injuries also out there that are scary, and the recovery takes a long time. A bunch of NBA players have had these problems, including Kobe Bryant had this problem. Basically, it's a sudden and forceful eccentric plantar flexion with acceleration. When you're pushing your foot through the floor, patient would describe like a pump sound in the posterior ankle. Sometimes they feel like they got shot in that area. The test, it would be the Thompson test, which is basically you squeeze the calf muscle, and if it's normal, you should see some plantar flexion movement. If you squeeze and there's no plantar flexion, then it can be a positive test. I like to do it prone and kind of squeeze that area. X-rays, ultrasound, and MRIs can be very good options. Ultrasound have been very popular right now, and that's what I use in my practice. And then the treatment is surgical versus non-surgical. An important concept is that before everybody got surgery, and now there's controversy if surgery is indicated on everybody or it can be treated as a conservative approach. So there's still some discrepancy at this age that what is the best option. So in terms of the non-surgical and surgical, so if the patient is a high-level basketball player, high school, college, professional, most likely they're going to get surgery. The main reason is that we want to make sure that it's reattached and we don't waste time and we do surgery and we do rehab and they do fine, because we don't want to do non-surgical, it doesn't work, and then we have to do surgical, and then it takes more time for the patient to come back. So the pros and cons of the non-surgical, usually we do that more in older patients, and we decide to do this approach, is that there's no risk of infection because there's no surgery. It actually has like a very similar return to play in that older population, so the recovery is pretty similar. The cons will be a delayed healing that can result in some weakness, and maybe there's like a slight higher re-rupture rate, but I feel it's still very small, that gap. Pros from the surgery is less risk of re-rupture, slightly better strength after 1 year, so in professional and high-level athlete, we prefer this option. But cons, there's a risk of surgical complication with the surgery. So in terms of the return to play after surgery, we're talking that the patient will have normal ambulation between 3 to 4 months or 5 months. We avoid running and non-contact sport for 16 to 20 weeks, and then we do a gradual return to run. So the idea of the first 3 months of rehab is preventing the re-rupture, making sure that the tendon heals. Then after 3 months, it's improving the strength of that tendon and the calf, and also the biomechanical aspect. Everything is connected, right? And then in 3 to 6 months, and I will say probably closer to 9 months also, we're going to progress the rehab program. Right. So now let's talk about one of the things that I like talking the most, which is the ACL tears. Lesiones al ligamento cruzado anterior. Ligamento cruzado anterior. ACL and anterior cruciate ligaments. So basically, it's an important ligament in the inside of the knee that kind of restrain the anterior tibial translation. So it's avoid la tibia moverse para el frente, ¿verdad? Anterior. The tibia translating anteriorly. So it's two major bundles in that area, and the etiology. So basically, the ACL improve with knee stability, especially when you're changing direction, like in basketball or soccer. So and football. That's why those sports are very high this injury. You can see here the picture of Klay Thompson when he injured his ACL. He landed in that position, which is called the position of no return, and we're going to talk a little bit more that soon, I think. Yes. So there's two types of injury. You have the non-contact, which is more common, or the contact. The contact usually is more common in football, even though it's still the non-contact more common in football. The contact injury is more common in football also, which is a injury on the outside of the knee and kind of breaks the MCL and the ACL also, sometimes the meniscus. The non-contact is more common, and the idea is that you jump and you try to change direction, for example, and then the hip goes to medially and the foot gets stable, and then that rotational motion kind of breaks the ACL. These are a few videos of injuries of ACL. We have Baron Davis right there in the top one. He had this kind of layup, and he planted his foot, and his hips and knee went different direction, and he had the injury. Then we have Danilo Gallinari with a similar kind of injury when he was penetrating to the basket. So the other concept that is important in terms of mechanism is the point of no return, which you can see here when you jump and you land in this way. When you're in the air, you cannot control your body. So you're going to land in a position, and if the body kind of goes to one side and the foot becomes stick in the floor, you can have this injury, and that's what happened with Klay Thompson. And we see this also a lot kind of in volleyball when they're jumping in one leg to try to hit the ball. So in terms of epidemiology, there's 250,000 ACL injuries each year in the United States. It's very common in females, so it's more common in females, especially in the level of high school. We see more injuries in males, but when you because more males play sports, but when you kind of do the analysis with hour of exposure, females are more predisposed to having this injury. High-risk sport is basketball, soccer, or American football due to the pivoting, cutting, and jumping. And this is the problem. The return to sports, 80% approximately return to participation in some type of sports after ACL. That means that they return to any sports, not necessarily the same one. 60% return to the pre-injury sports, so only 60% came back to basketball, for example, and only like less than 50% return to the same level of sports. So it's a big injury that can affect your performance. And if you see the trajectory of more professional players that have an ACL injury, most of them, their performance decreased significantly. Their growth happened. Klay Thompson has decreased a little bit. And I think with the exception of Andrea Peterson, when he won the MVP the year after of the ACL surgery, everybody else tend to decrease the performance. Different risk factors. We have intrinsic risk factors and extrinsic risk factors. Intrinsic would be like sex or gender or sex. It would be more females, hormonal status. There's some data that depending on the what stage of your period the females are, it can increase the chances in that stage. And there's some genetics involved. There are muscular deficits and problems in anatomy, and a history of previous ACL predispose you to having a second ACL. Extrinsic risk factors would be the level and type of activity. So if you play basketball, football, soccer, you're at higher risk. If maybe you play other sports like judo or martial arts are less risky. The surface also is important. For example, not necessarily in basketball, but in soccer or football, we know that turf field, like fake grass, has a higher risk of ACL tear. So that's why more professional sports are not playing in turf fields. And the reason is that the grass tend to give out and kind of break. So the foot doesn't get stuck and you're developing this pivotal injury. The environmental condition also has a risk factor. We know that if it's raining, there's a less risk of ACL injuries. And in some soccer stadium, they water the field at the beginning of the game and during halftime, also to decrease the risk of ACL injuries. And the equipment, also like the shoes, before they used like the spikes were larger, and that increased the chances of having ACL. So now they're a little bit smaller. Neuromuscular control, very important as part of the rehab process, and to evaluate the risk factors. So increasing dynamic knee valgus, decrease hip and knee flexion, and increase internal rotation of the hips can be risk factors. Also increase quadricep muscle activation. So if you have strong hamstrings, that can help protect the ACL tears. If the hamstring is significantly weaker than the quadricep, which it usually is, but the ratio is kind of altered, it can be a risk factor. So what is the history of physical examination of ACL tears? So the history, he's going to say that he feels like a pop sensation. Usually they're going to tell you that they were trying to change direction or they were jumping. So try to ask about the mechanism of injury. They develop rapid swelling, which is important concept, that the patients develop swelling a few hours after the injury. If the swelling is the next day, usually that's more consistent with maybe meniscal injuries. If the swelling is very quickly, the suspicion of an ACL injury is very high. So that's something to evaluate. Physical examination, and apart from inspection and range of motion, all those things, the special maneuvers are the Lachman test, which is the most sensitive one. And that's a board question, by the way, that comes in the PM&R boards. And the pivot test, which is another one, but that one is kind of hard to do, which basically you're trying to kind of do the dynamic valgus with movement, and the patient don't like it. So it's hard to do. Sometimes we do it more in the OR because the patient is asleep, and we can try to test the knee to see stability. And then the anterior door test that can be also considered. X-rays can be done to make sure that there's no fracture, and there's also the C-gun fracture, which is a kind of a finding that it can be suggestive of ACL tears. Sometimes if I tend to aspirate the knee, and if there's blood, my suspicion of ACL is very high because the ACL is very vascular. It has like a vessel inside, so if it breaks, it bleeds blood. But the MRI is still the gold standard because I cannot see very well the ACL with the ultrasound. So the MRI would be better. Treatment, then we discuss surgery versus non-surgical. I'm not going to get too much into it, but in high level, younger patients, surgery usually is recommended. In older patients or in patients that their sport do not require a lot of changing direction, it can be considered as an option. So I created this kind of ACL rehab kind of diagram to kind of try to take you to the different aspect of the rehabilitation program. In my experience back in Puerto Rico, we took care of the ACL rehabilitation. So we were the one, PM&R providers were the one making the decision that the patient is ready to return to play. Here in the States, usually it's the surgeon with the physical therapist. The physical therapists have a lot of freedom in their decision, but I truly believe that PM&R are the expert in rehabilitation, so I think they should be part of the rehabilitation decision making, but it's something that is not seen very frequently in the United States. So if you have a player that got that ACL injury, then we start some preoperative rehabilitation or prehab. So the goal is basically starting some physical therapy. Sometimes I aspirate the knee to improve the range of motion, decrease the swelling of the knee. The idea is that we cannot do surgery unless the patient has full range of motion and is activating a little bit better the quadricep, because this will improve the outcomes of surgery. So we want to reduce the knee swelling, achieve full motion and normal strength. And that can take weeks to months. ACL surgeries, you don't need to do it the next day. It's not an emergency surgery. It can wait weeks, it can wait months. However, in professional players, usually it's done very quickly to start the recovery aspect. But in some patients, we can definitely do a prehab modality to try to get them ready for surgery. So if they have surgery, the surgical option is they can use an allograft, which is a cadaver ligament. This usually is a higher cost, and it has a high failure rate compared to autograft. So we tend to do more dose in older patients. In younger patients, usually we prefer autograft, and in pediatrics, definitely autograft is recommended. So in terms of autograft, we can use el tendón patelar, which is the patellar tendon. We can use el tendón del hamstring, o isquiotibial en español, tendón de isquiotibiales, hamstring tendons, or tendón del quadricep, que es quadricep tendon. The quadricep tendon is kind of a little bit newer. The classic one has been patellar and hamstring, but the quadricep has gained a lot of popularity because for patellar tendon, some patients develop this kind of chronic pain in the anterior knee where the graft was taking off. In hamstring tendon, they can have some weakness in the hamstring or pain in there. In the quadricep tendon, it seems that it has less morbidity compared to the other ones. So recently, it has been very popular option. And that's a discussion that to have with the surgeon, and he decides which one is better. And then what is the goal of post-surgical rehabilitation, right? So the acute phase after surgery, we want early weight bearing, reducing pain and swelling, improving range of motion. And we want to start that quadricep activation, because sometimes if it turns off, it's very hard to turn it back on. So definitely we want to start that process quickly. Then after we regain all those goals, we transition to the recovery phase, which basically we're doing a strengthening program. And we can start with closed kinetic chains, and we transition to open kinetic chain exercise. We start doing some neuromuscular control and balance of proprioceptive exercise. And this will take month of rehabilitation to try to get them back. And then at the end, we do the functional phase with basically we're doing more sport-specific training to try to regain the performance at that point. So there's some clinical screening for strength and functional testing. So the patient is doing all this strengthening. So before, they use like a time frame, like, hey, you have been doing it for 6 months, 9 months, or whatever, you're good to go, because at this point you're good. Now we're doing more of an objective kind of approach. And in the physical examination, I want to see, number one, good knee stability on physical exam, adequate strength, and adequate neuromuscular control before we decide to take these kind of objective measures. So this probably would be close to kind of 6 to 9 months is when we're kind of evaluating this. And then in 6 to 9 months, we start considering if we want to do isokinetic strength evaluation, which basically we use a isokinetic machine, like the Cybex. And we measure the power of the hamstring, the power of the quads, and we compare that with the good side or the contralateral side. And we want to get close to less than 10% of difference of strength between both sides. If the patient has 20% deficit, they need to get back to the gym, physical therapy, continue with the strengthening program to try to get it close to less than 10%. Closer to 0 is perfect, but closer to 10 is kind of the goal that we want to achieve. And also we want to achieve that kind of 65% ratio in strength in between the hamstring and quads. And then there's some data and some articles that have, depending on your sport and your age, they have some values that are optimal, because The big problem and the confusion is that we compare with the contralateral side, but if the other side is also weak, maybe that's still not optimal. So it's something that can be confusing. So sometimes it's good to see some basic numbers to make sure that we're having good strength. And after the patient kind of pass this test that they have less than 10% of difference, we can transition to a more specific rehabilitation goals. And then we start doing more like gym work, field play work, and more maybe basketball course exercises at that point. And after they kind of feel pretty good with that, we start doing some functional evaluation. And basically, these are functional tests that they're standardized, and we incorporate some jump, hops, running. So these are some examples here. So we do the single hop test for usually you can do like 3 to 6 tests depending on what you want to do. And once they pass that is when we are start talking, okay, let's get you back into the field, let's start practicing in the course. And then after 9 to 12 months is when we make the clearance to allow you back to competition. And I say 12 months, but it can be longer than that in some cases. Definitely, nobody should be returning before 9 months because the risk of re-rupture is very high. After 9 months, they should pass through all this protocol to get them better. So in terms of making the decision to return to play, physical exam, make sure it feels stable. The physical exam is good, full range of motion, good strength. We do the isokinetic testing and the functional testing. And something that we cannot forget is the psychological readiness, because sometimes the player pass all the tests, but when you ask them if they feel ready, they say no. So if they're not mentally ready, they should not be getting back. And that's where sports psychology can help and different modalities. My personal preference is starting sports psychology from the beginning. And we get that rapport with the psychologist to get them through also through this process, because this is becoming a very important concept. All right. I'm not going to talk too much about this because I want to make sure that I have time to answer questions, but just briefly, ACL injury prevention. So there's a few protocols there that has been described that it can be beneficial for patients. The most common one is the FIFA 11 plus, or now it's called the 11 plus. It was developed by FIFA. And it's a combination of warm-ups that you can do 2 to 3 times per week after games or before games or before practices that focus in the physiological and neuromuscular preparation. It can be done by ATCs, the therapists, the coaches, but they have to have knowledge to see if they're doing it correctly or not, because if they do it incorrectly, they're not helping. I'm not going to get into a lot of details, but it incorporates some running exercise like you can see here, strength, biometric, and balance exercise like you see here, and then more advanced stuff like you see here, right here, and then some more pivoting motion in your warm-up. So they also have developed this in kids, which is a little bit more friendly. It's kind of more kind of playing kind of concept, so for them to do it. So what is the evidence about this? And there's a few articles that review the evidence, but in summarize, basically, there's evidence that the 11 plus program can decrease the injuries 33%, in practice 29% in matches. So it have an overall risk reduction of 34%. But the important thing, it can decrease the severe knee injuries, especially in the lower extremity, by 50%, like ACL injuries, for example. So those are the injuries that take too much time to rehab. It might require surgery. So those are truly the one that we want to prevent. And you can see here an example of how this player was running with a 16 degrees of hip drop, knee valgus, and knee collapse. She jumped, and you can see this kind of valgus deformity, not deformity, but kind of angle. And then after the treatment and strengthening program, then they have better pelvic alignment, and you decrease the risk factor of the neuromuscular aspect. So it sounds great, right? It's magic. So why do we still have ACL, a lot of ACL injuries? And the problem is that nobody does this. Nobody does this program. And so it has been shown that the higher the compliance rate, it works, right? If you do it, it works. If you don't do it, it doesn't work. So one of the things that also has been found is that less injuries is equal to more wins, which equals more championship, right? So these are the things that you have to bring to the coaches, to the ATCs, like, hey, we need to implement this because they will mean less injury, and less injury means more wins, which is the goal of everybody. And the key component is the coach. You have to convince the coach. If the coach is not on board, this is never going to happen. So you have to educate the coach about the importance of this for them to do it. So there's a big study that they did in professional soccer players, which shows that only 11% of the teams were doing this preventive program in professional players. So if in professional teams they don't do it and follow it clearly, college teams and high school teams will do it less. So this is something that needs to be implemented from the high school and college level, and hopefully in the professional. So I just wanted to give like 10 minutes for questions. So I just did that. So this is my email if you have questions or you have any other question about PM&R. I just wanted to bring also that we're opening our PM&R residency, which is great. So we're in Mayo Clinic, Florida, in Jacksonville. Finally, we are opening our PM&R residency. We're excited. So we're interviewing this season. So if you're MS4 and you're interested in PM&R, which probably you are because you're here, is that we consider us. There's some website that you can look up online. You can put PM&R Mayo Clinic Jacksonville residency, and then you can find a lot of information. I'm happy to answer any information that you might have in the email that I put there. So I just open it up now for questions. I've been talking a lot, I'm thirsty, so I will leave anybody else to talk for a few minutes, and then I can answer any questions.
Okay, I did want to add on the chat a link with the PM&R program that Dr. Rosario Concepcion was talking about. That's the Mayo Florida program. So you can always go in there and check it out and get information from that website. I'm also going to add another link right under it, which is just like a feedback form. We just like to hear what y'all think, and if there's any specific topics that you want to listen or like hear about. I know I liked the sports medicine stuff, so I was really interested in hearing about this. But I want to know what else the rest of the group wants to listen to, and so please fill out that form. But yeah, if you have any questions, this is a good time to unmic and ask away. If you are shy and don't want to do that, you can also put it on the chat or send it directly to me as a DM, and then I can ask on your behalf. And while that's trickling in, Dr. Rosario, I did have a question. I was wondering if you could talk to us a little bit about how you came to find sports medicine, your interest in the specialties. That's something that you knew right away whenever you found that you wanted to do PM&R, or did you find it later?
So actually, I wanted to do sports before PM&R. And so I wanted to be a sports doctor and be a team physician and all those things. Wait, I'm getting cold. Give me a second here. Okay, I can call them in a few minutes. I'm on call today. And so I wanted to do sports medicine, and actually back in Puerto Rico, the sports medicine primary care doctors are PM&R guys, and they have their own private practice and they do clinics. So if you get an ankle sprain, everybody goes to the PM&R first. They don't go to the orthopedics, they don't go to family medicine sports, they go to the PM&R. And so in my mind, the route to do sports was PM&R. But then I found out that PM&R is not just sports, right? It's another, it involves a broader spectrum of function and independence and all those things. And the more I read into it, the more I like it and kind of goes to my interest. So I kind of fell in love with PM&R, and definitely I'm very proud to be a PM&R doctor, which is kind of way different than any other specialty in my opinion, and the rewarding is kind of very high. But then I'm also a sports doctor, but I'm proud of both. Any other questions? Perfect.
Oh.
Yes. Somebody talk.
We can hear you, Caitlin.
Can everybody hear me?
Yeah.
Okay. My mic is broken on my AirPods. But I had a question like regarding the ankle braces. Like growing up, I played a bunch of sports. I played college basketball, and I was always told that ankle braces will make your ankles weaker if you use them if you've never had a sprain before. Is that true, or is that just myth?
So that's a great question, and that's one of the reasons that I like bracing overall in the body, like knee braces, back braces, and all those things, due to the evidence of it can weaken the muscles around that area. However, for the ankle joint, definitely if you only use the brace and do not do any strengthening program at the same time, yes, it can make things worse. It can weaken the muscles more. But the idea of the brace is that you're going to use it while you play basketball. You're going to use it when you're pivoting and changing direction. But at the same time, you're doing strengthening program, you're doing balance and proprioceptive exercise, you're rehabilitating that. So the brace is basically to prevent a second ankle sprain while you're playing, and there's data that it can do that. There's data that it can prevent ankle sprains from primary ankle sprain, like if you never had it, it can prevent it. But my thought with that is that if we do that, you need to be also doing some strengthening, some balance and proprioception to avoid basically the weakening of the muscles around there. So it's true that in terms of that concept, but you can decrease that chances of happening if you actually doing a strengthening program in addition to that.
Gotcha. Cool. Thank you.
I have a question, if that's okay. I just wanted to ask you, Dr. Rosario, what are some things that you think would be really helpful for those that don't speak Spanish and want to incorporate more medical Spanish into their practice, specifically in sports medicine? What are some things that are that would be really helpful for them to know? Like, for example, different parts of the body that come up a lot, or different medications that they use a lot, things like that.
Yeah, definitely. Basically, trying to learn the terminology in Spanish, which is different, and it can be different also in Spanish in different Spanish-speaking countries. For Puerto Rico, we call it a tendón patelar, but I know in other places it's a tendón rotuliano. So in other countries in Latin America, so it's just learning those concepts. Rotator cuff is manguillo rotador. So different medical concept, I think, would be beneficial, and things that you see frequently, probably start with that. And if you see a lot of ankle sprain, then learn esguince de tobillo. If you see a lot of back pain, just dolor de espalda. Try to learn these kind of symptoms and concept in Spanish, and start with that, and then move your way then after to medication, which I think is a little bit more challenging, and go from there.
Thank you.
Hey, doctor. Can you hear me?
Yes.
So,
Are
saludos,
you from
doctor.
Puerto Rico?
Sí, soy de Puerto Rico. Sí.
Yeah, you UCC is one of the medical school in Puerto Rico.
Sí. Pues nada, doctor. So I had a question. First of all, your presentation was good. Awesome.
It
So
was
I
not
heard,
great.
yeah,
Was good.
great.
Was
Awesome.
good.
It was awesome. So many interesting things. So I've heard that soccer players return to play before the 9-month period after any kind of ACL injury. Is that true?
They should not, but they do, depending on their knowledge of their surgeon and their rehabilitation provider. The reason is that there's a big article that says that every month that you wait, you decrease the chances of a re-rupture of the ACL or a rupture in the contralateral side by almost 10% every month, until you are right at the 9-month stage where that difference is not that big. So that's why we say that 9 months should be the time frame to return at the earliest. Even if they pass all the tests, because sometimes they pass all the tests, they're feeling great. And the reason is, and the theory is, that the ligament requires some time to kind of get stronger. So before 9 months, it's not strong enough to tolerate those activities. So there's a decision in terms of time, there's a decision in terms of objective measure like the strength, and there's a decision in terms of functional testing like we discussed. And then there's the psychological aspect that we discussed also that had to be into account. However, if you don't know this and you're a surgeon, then if the patient feels that it's ready and you don't have a good protocol of return to play, yeah, you're going to see that they return before the 9 month in some cases, but there's a higher risk of having a re-rupture and a rupture in the contralateral side higher. There's special cases that the patient has the last senior game 7 months and they're never going to play again. And you're like, okay, whatever, go play your last season or whatever. But if they're planning of kind of longer terms, it's not a good idea to play. And that's my perspective. And you can look for a lot of articles that actually were written by Dr. Michel and their team there in Puerto Rico, which was my Sherman there in Puerto Rico, which has written a lot of the rehab protocols for ACL return to play. And those are a lot of the references that I brought in my slides.
Yeah, I noticed. Gracias, doctor.
All right, you're welcome.
All right. It's 7:02, so Dr. Rosario Concepcion. Again, we just want to say thank you so much. Muchas gracias por su tiempo. And thank you everyone for joining us today. Please do fill out that form with feedback so we know exactly what it is that you'll want to see in the future. And then we'll be sending more emails soon to kind of let y'all know about future opportunities that we're going to have within our network. Muchas gracias a todos. Que tengan muy buenas noches.
Gracias.